This is part 2 of my e-lecture on polycystic ovarian syndrome, where I am going to discuss the diagnosis and treatment of PCOS. I request you to watch part 1 of my e-lecture on PCOS before watching this video. Diagnosis of PCOS involves answering the following questions. Are the ovaries polycystic? This can be done by ultrasonography or laparoscopy. Is there evidence of hyperandrogenism? This requires endocrine investigations. Is there insulin resistance? This requires fasting and postprandial insulin and glucose levels. Are there any other associated abnormalities? For this, some special investigations must be done to rule out other conditions that are the differential diagnosis of PCOS. In order to diagnose polycystic ovaries, a transvaginal ultrasound scan is preferred to a transabdominal scan because transabdominal scan can miss up to 25% of cases. The PCOS ovaries are typically 1.5 to 3 times the normal size, that is, their volume is greater than 10 ml. The finding of more than 10 follicles of 2 to 10 millimeters in diameter in the entire ovary meets the generally established ultrasound criteria of PCOS. Often, the cysts of PCOS are located in a peripheral subcortical ring leading to the reference of a string of pearls appearance. The ovarian stroma is dense. Different criteria used to establish the diagnosis of PCOS on ultrasound are Adams criteria, at least 10 cysts of 2 to 18 millimeters diameter seen in a single plane arranged around a prominent stroma. Fox's criteria, at least 15 follicles of 2 to 10 millimeters diameter, hyperechogenic stroma, ovarian volume greater than 8 ml. It must be noted that polycystic ovaries are found in a wide variety of unrelated disorders, including up to 30% of women with normal menses and normal circulating androgens. The other modality commonly used to diagnose PCOS is a laparoscopy. At laparoscopy, the ovaries are bilaterally enlarged, that is, equal to or larger than the size of the fundus of the uterus, and encapsulated by a thickened outer tunica albuginea that is similar to an oyster shell in appearance and color. The ovaries are so enlarged that instead of lying far apart along the lateral pelvic walls, they are seen touching each other behind the body of the uterus. This appearance is referred to as the kissing ovaries, as shown here. Now I will discuss the various endocrine investigations which are done for diagnosis of hyperandrogenism. First of all, the timing of performing endocrine investigations is important. As a rule, endocrine testing is probably best performed in the morning, soon after a spontaneous or induced menses, that is, on day 2 of menses. The endocrine evaluation of hirsutism includes measurement of serum total testosterone in the early morning hours. If the testosterone levels are not elevated, then measurement of free serum testosterone may be considered. Although LH-FSH ratio greater than 3 was considered indicative of PCOS, now we know that LH and FSH ratio adds little value in making the diagnosis. Increased LH levels are more common in lean and non-obese PCOS women than in their overweight or obese counterparts. Investigations for diagnosis of insulin resistance are important because both obese and non-obese women with PCOS exhibit insulin resistance. For diagnosing insulin resistance, fasting and postprandial glucose and fasting and postprandial insulin levels are measured, and then HOMA index is calculated. HOMA stands for Homeostatic Model Assessment. It is a method used to quantify insulin resistance and beta cell function. It is given by the formula Insulin resistance HOMA index is equal to fasting glucose multiplied by insulin levels divided by 405. It is measured in mass units milligrams per deciliter.